of that initiative. And so we are happy and thrilled today to welcome Dr. Kimberly Roth, and I'll share a little bit about her background, and then I will turn it over to you, Dr. Roth. So Dr. Roth earned a Master's of Health Science and PhD from the Mental Health Department at Johns Hopkins Bloomberg School of Public Health. She then completed an NIMH-funded postdoctoral fellowship at the Center for Mental Health Services Research in the Brown School of Social Work at Washington University in St. Louis. Okay, I did that all. It was a mouthful. Currently, her research focuses on the epidemiology of mental disorders in Latinx populations, both in the US and globally. Dr. Roth is especially interested in the application of advanced statistical techniques to answer complex questions regarding immigrant and minority mental health, in particular, the integration of psychiatric epidemiology, geospatial information systems, and latent variable methods to address contextual factors affecting mental health in these populations. Since coming to Mercer University, she has expanded her focus to the health of rural populations, specifically as it relates to suicide prevention and the opioid epidemic. Her active projects also include addressing the mental health needs of farm workers and understanding autism service deserts in Georgia. So welcome, Dr. Roth.
Thank you so much, Dr. Kemp. I really appreciate the introduction. Let me go ahead and share my screen. Okay, can you see my screen? Okay,
Yes, we can.
great. All right. So yeah, I today am going to talk to you about opioid use in rural populations. I'm going to come at it from a epidemiologic point of view, because as Dr. Kemp mentioned, I'm a psychiatric epidemiologist, which is really just a fancy way of saying I'm interested in mental and behavioral disorders in populations. And in particular, I'm interested in health disparity populations. So yeah, before we dive into rural specifically, I wanted to make sure we're all on the same page in terms of the opioid epidemic. So how did we get here? It's been a long, it feels like it's been forever, but it really started in the mid to late 90s, where prescription opioid painkillers triggered the crisis. There wasn't a lot of attention to it at the time. Then in 2011, heroin deaths began to surge in the US. And if I remember correctly from my training, it was actually because they were aware of the prescription opioid problem. And now I'm blanking on the manufacturer of OxyContin, but they reconfigured their pills so that they weren't as easily abused. I think like they weren't as easily crushed and turned into something. And so people who were misusing opioids had to turn to heroin. So that kind of spiked the heroin deaths. And then in 2014, fentanyl sort of started to rear its ugly head, and we're still kind of grappling with that these days. I personally hadn't heard of fentanyl back then, but I think everyone has now. And then in 2016, cocaine deaths began rising. And then in 2020, fentanyl, methamphetamine, and cocaine deaths are accelerating, in large part due to the pandemic. Okay, so here's a nice graph that I like. We like to think of three waves of opioid overdose deaths. The first is, like I said, in the late 90s with the rise in prescription opioid deaths. And then again, the rise in heroin deaths in this blue line, 2010, 2011. And then synthetic opioids like fentanyl really started taking off in between 2013 and 2015, really. And you can see in the purple line here, the synthetics, they have really surged in recent years. Now, something that this graph doesn't show is that it's actually encouraging that in the last year, probably since 2022, 2023, deaths have started to slightly decline, which is really hopeful. Um, but anyway, so that's just kind of a snapshot of what the opioid epidemic looks like in the US. Here's what it looks like with some through a like geographic variation lens. You can see that the hardest hit parts are really Appalachia, all the way up to like Maine. So it's like the Northeast that's really struggling here. And interestingly, you can see Georgia down here, and we're not the worst, but we're not the best. So we still struggle, but definitely not on the level as it's seen in like Appalachia. But I will say that what this map doesn't show is, and we'll get into this in a little later, but as those of you know, like we do have a few counties in the upper, like the Northwest Georgia area that are considered Appalachian counties. And then this is just another graph showing opioid deaths in Georgia, and really it mirrors the graph from the overall epidemic. So Georgia hasn't been spared. But it really is striking this increase. It's in less than 25 years, the mortality rate related to opioids has had an increase of about 25-fold. So that's truly staggering. And then the last thing I wanted to talk about, and this is, my public health background. We talk a lot in public health about what's called the social ecological framework. And this was a publication from 2020 that really adapted this framework to the opioid crisis. And basically, if you haven't heard of it, the social ecological framework basically just posits that individuals are placed at the center of these like expanding concentric circles of influence. So your health is not just decided by your individual level characteristics and behaviors. It has a lot to do with your family and your friends, your social network, the community that you live in, and the broader society at large. And so you can see here that yes, there are sociodemographic factors, stress and trauma exposure, biological and genetics that affect whether or not someone misuses opioids. But it also depends on, again, like I said, your social network, family history of substance abuse. A lot of times, particularly prescription misuse, access is through your friends and family. And then at the community level, there's a lot of treatment related variables. Community norms are huge. Um, Again, there's geographic variations, and the workplace and school environment also influence. And then at the larger society, there are things like laws, educational campaigns, what insurance will cover, things like social stigma and discrimination and prejudice. So yeah, you can see that the factors are broad, but that really we'll talk about this later. We'll revisit this, but I just wanted you all to get a sense of really what's driving opioid use in an individual, and really it's all these things influence whether someone ends up misusing opioids. Okay, so let's pivot to opioid use in rural areas. So it really has become a significant public health concern over the past 2 decades. In many ways, rural communities suffer disproportionately. So their raw numbers might not be as staggering if you're looking at just like counts of opioid deaths in rural areas, but things like earlier age of onset for use in rural areas, higher odds of use in rural areas, more likely to have harms of intravenous use, so acquiring infections like Hep C, Hep B, HIV. The other thing is that generally rates of opioid use in rural communities have been increasing faster. So while they might have started lower, they're really, it's just kind of skyrocketing more than it is in non-rural areas. But the thing to keep in mind, and we'll talk about this, is that there is considerable variability in opioid-related mortality within rural areas. So you can't think of all rural areas as the same. Um, I mean, I could go off on a tangent about how we measure rurality and how we think about it, and it's really, woo, I could give a whole lecture just on that. So we're not going to do that today, but we are going to explore a little bit about this variability in opioid-related mortality. Okay, so I mentioned that there are increasing mortality rates and it's faster in rural areas. So I know this graph kind of isn't maybe the easiest to read, but basically these authors broke up areas into whether they were large central metro all the way down to non-core metro. And we generally think of these three in the red box, which are also the gray lines, as being more rural. So if you can look here in the graph in 99, the three gray lines are all really low comparatively towards the non-rural areas. But you can see overall over time, they're really growing more rapidly. And in some cases, some of the places have really exceeded some of the non-rural areas. Now, in recent years, you can see that there's been a large spike, but particularly in urban areas. But over time, you can see if you sort of do the numbers in the three rural counties, which I have noted here in red, those are the three highest rates of increase in age-adjusted related mortality by metro status. And then this is just a similar graph to what I showed before, but it's only among rural designated counties in the US. So really the biggest thing to note is it looks a lot like the overall US map that I showed you just a few slides ago. A few variations, like you can see Utah. I'm like, what state is that? Utah. Um, Utah kind of standing out. But generally, you just see that Appalachia is the hardest hit. And then the Great Plains are really lower on the deaths per 100,000 population. So something else to note about opioid use in rural versus non-rural areas is the type of opioid that is misused. So these two panels here show the percentage of drug overdose deaths that are due to a specific type of opioid. So at the top here are prescription opioids. On the left-hand side is rural and the right-hand side is urban. So we have this dashed line, which is prescription opioids. And you can see, particularly in earlier years, the percentage of deaths due to prescription opioids makes up just a larger share of the deaths than it does in urban deaths. Also, you can see that up until recently, the same was true for synthetic opioids in rural areas. Much more of a problem. You can see hovering between 5 and 10%, hitting 10% around 2008, 2009, whereas it was closer to 5% all the way up to 2013 in urban areas. And then finally, in urban areas, heroin has been traditionally much more of a problem, and makes up much more of the overdose deaths. Okay, so in addition to all the things that I just said, rural communities face unique challenges related to opioid use, including higher rates of prescribing opioids, greater stigma surrounding addiction, a lack of privacy just due to the nature of the social networks in rural areas. And this, we'll talk about this again later, but this includes healthcare providers, so relationships and stigma with among healthcare providers. Rural communities have a lot of structural stressors. So these are things like unemployment, poverty, things that we would traditionally think of as the social determinants of health, if you've heard that term before. But it also includes things like lack of infrastructure and transportation. In general, there's limited access to treatment services in rural areas. So people who do find themselves with an opioid use disorder, for example, just don't have a lot of options. And you kind of combine that with geographic isolation, where it's hard to get places, again, because of that lack of transportation, public transportation. It can just be a recipe for failure. And then finally, in rural areas, people are much more likely to work manual labor jobs. And these jobs are physically demanding and they are more prone to injury, which is all related to pain and therefore why people would need opioids prescribed in the first place. Okay, so I mentioned the higher prescribing rates. When I had first heard that, I was a little shocked. This is a paper that does the percentage of the population. I guess this was taken from electronic health records, I believe. Percentage of the patient population that were receiving an opioid prescription. And you can see that, again, these are the same categories we looked at before in that one graph, but non-core is the most rural and large central metro is the most urban. And so this is like a gradient, and you can see the gradient is reflected in these prescribing rates with, almost 10% of patients receiving an opioid prescription in non-core counties, but in large central metros, almost half that. And then this is just a graph showing the same thing, but just trends over time. And again, these two lines that I have with the red arrows pointing, those are our two most rural designations, metro designations. And you can see that they're consistently higher and that in the first time period chunk, they were also increasing in contrast to the other four metro area designations. So why is this happening? It could be that prescription drug use and misuse, like I said, that there's an earlier age of onset in rural areas. There's possibly a higher prevalence of chronic pain, like I said, related to these manual labor jobs. Rural areas often have a larger older adult population, and they have a lot of conditions that are associated with pain, or that pain comes along with. Prescribing is often strongly influenced by the provider-patient relationship. And so if you have a personal relationship with your provider, they might be more likely to disregard prescribing guidelines. Again, limited access to opioid use disorder treatment and alternative therapies. And then there are also just variations in the implementation of PDMPs, which off the top of my head, I can't remember what that stands for, but that's where providers have to report or log the fact that they've prescribed these restricted use substances. So things like there's just variation in what's allowable and not allowable, and that can be different between rural and urban areas. So I also mentioned stigma. Stigma is actually a huge problem. And so a definition of public stigma is basically negative attitudes towards a specific group of people among the general public. And ways that we sort of figure this out in the epidemiology world is asking people questions like, would you want to live next door to somebody who misuses opioids? Or would you want your child to marry someone who has an opioid use disorder? And so coming at it from that perspective, um, a study done found that 78% of Americans believe that people who are addicted to prescription opioids are themselves to blame for the problem. And 72% believe that people addicted to prescription opioids lack self-discipline. So basically, the view is that opioid addiction is due to poor individual choices and lack of discipline. And this has effects all across the social ecological model. So people feel it at the individual level, but it also leads to unwillingness to allocate resources and provide programs at the community and the society level, and also interpersonal isolation. Like I said, people don't want to be good friends with someone with an opioid use disorder. They don't want to live next to them. They don't want their child to marry someone with an opioid use disorder. And we know, for better or for worse, stigma is higher in rural areas. Um, and unfortunately, stigma is a significant barrier to accessing treatment and support services for individuals with a substance use disorder. So not only does it make somebody less likely to take that first step and access OUD treatment for the first time, but it makes them less likely to sustain treatment, to be actively involved in recovery. And then just generally, there's research that shows that stigma is associated with worse physical health, worse mental health, and also non-fatal overdose. So I found this interesting qualitative study put out in 2021 from rural Maine, which I know is very different from Georgia, but they did 10 focus groups and they wanted to understand how stigma affects treatment and recovery. And so I thought there were some very powerful quotes in this article. So for instance, this one person in recovery said, "I went to the hospital for my teeth. I have really rotten teeth." And they saw that previous drug use and said I was drug seeking. I wasn't asking for pain meds. I needed antibiotics. And another person said, pharmacists are not nice when you go in to get thyroid meds. Or sorry, pharmacists are nice when you go in to get thyroid meds, but they're not the same when you go in to get your Suboxone. They change and they're not even nice. So these authors basically found that healthcare settings was the most common place that people in recovery experienced stigma, which is a little disconcerting because that is an active barrier to people getting the help that they need. So from their analysis, they found that stigma affects treatment and recovery in 4 ways. One way is this pathway that they call secrecy, which is the habit or practice of keeping secrets or maintaining privacy or concealment. And it's basically not wanting others to know that you're in recovery, that you're receiving these services. If you leave work, you can't be honest about the reason why you're leaving work, that kind of thing. Or maybe you're not telling family members. Another pathway is resilience, or the ability to recover or adjust to misfortune or change. And this is actually the opposite. So it's somebody being told they want to prove people wrong, basically. So they want to show that they are doing well and that they can, come out on top. Um, and so that's pretty cool. I liked that finding. On the other hand, they also found a resignation pathway, so the acceptance of something undesirable. And this is basically like if somebody thinks you're doing it, you may as well just do it. So this is in direct competition with the resilience pathway that some people take. And then finally, there's a lot of fear. And so people go and visit their healthcare provider, and they're afraid of them being judgmental, or they're scared that the DHHS was going to come and take their baby. So fear, particularly surrounding services, not just health services, but services in general. Okay, and then finally, I mentioned that there's limited access to treatment in rural areas. So there are fewer providers and treatment options. In general, it's more difficult to recruit and retain providers in rural areas. It's rare to find a detox center in a rural area, and access to medication-assisted treatment, which is the gold standard for treatment of opioid use disorder, is very limited in rural areas. And this is complicated by the fact that the treatment options that are available are dispersed across large geographic areas. So that makes long travel times to access your treatment. There are few public transportation options in rural areas, and this just in general makes access difficult. And if you put this in perspective, so many, if not all people who receive, I'll say many, most people who are receiving medication-assisted treatment or MAT, they have to go daily. Like if they're receiving methadone in particular, they have to go daily to the methadone clinic. And so think about someone who lives really far away. The public transportation is substandard or non-existent. Maybe they don't have access to a car. That's just really some huge burdens that people have to bear in rural areas. So I did want to mention that telemedicine can bridge some of these gaps. However, there are issues with broadband coverage in rural areas. So it's a little bit of a it's not a double-edged sword. It's more of like it's not a silver bullet. But it can help. Now, the drawback, and I apologize that I don't know the current state of things, but it used to be that, for instance, for someone to get access methadone, telehealth was not an option, like legally. In the pandemic, a lot of places rolled out these measures where people could actually access their medication through telemedicine instead of having to go in person. And there were also some concessions around the fact that maybe they could get their medication in the mail and get like a 30-day supply or something. But my understanding is that most, if not all, of these measures have been rolled back now that the pandemic is over. And then in rural areas, there's just also limited access to other types of services. So harm reduction activities are less common. So these are like syringe service programs. And this is due in a lot to the cultural belief that in abstinence, basically, that it's better to not use rather than trying to mitigate the harms of somebody who is using. Rural areas are less likely to adopt drug prevention programs. And even if they do, evidence-based national programs are rarely adapted to rural culture, which makes them we'll talk about this in a minute, but makes them a little bit more difficult to actually be successful. There are few drug treatment courts. So these are places where an offender is less likely So an offender is diverted from prison and into treatment. So this is less likely to occur in rural areas. And then there are just, in general, primary healthcare shortages. So there are more untreated injuries, more chronic pain, and people are forced to rely more on emergency departments. So now I'm going to just give you a little bit into some work that I did looking at opioid-related morbidity and mortality in Georgia, and it's a geospatial analysis. And so again, our objective was just to really provide a geospatial snapshot of Georgia's opioid epidemic, but we used several metrics of morbidity and mortality. And this was important because a lot of people most often people just look at, drug overdose mortality. But we thought that there were other measures that might be informative and possibly might not match up with the trends in mortality. So we used county level data from the Georgia Department of Public Health for all of Georgia's counties on 4 outcomes. We looked at opioid-related mortality. We looked at opioid-related inpatient hospitalizations. We looked at opioid-related emergency department visits. And then we looked at naloxone or overdose reversal administrations performed by EMS technicians. And then we got some sociodemographic data at the county level from the American Community Survey, which is part of the census. And then I'm not going to harp on the analysis, just know that we were interested in identifying hot and cold spots throughout the state to see whether any of these metrics were either more prevalent or less prevalent than expected in areas. And then we did some modeling to just see whether rurality was related to any of these, to the rates of any of these outcomes. So first, here's a graph showing the geospatial variation across the state of Georgia for these 4 outcomes. And I think the main take home here is that they're not the same. So if you're looking at overdose deaths, you see a pretty clear in like central Georgia, a pretty clear lower is fewer deaths. I mean, sorry, lighter is fewer deaths. And so you can see Central Georgia actually is doing pretty well. But that's not the case for ED visits or hospitalizations. And then also I wanted to draw your attention to the northwest corner, which is where the Appalachian counties are. And you can see that, for instance, ED visits are pretty low, but you can see in particular with overdose reversals and hospitalizations, like Northwest Georgia is really struggling. And so this is just a map that shows these hot and cold spots, like I mentioned. So the dark blue is a cold spot. So it's basically like they're much less likely to have the outcome, and then the red is the hotspots, so much more likely. And this pretty much confirms what we were looking at in the last slide. Again, for overdose deaths, we see Central Georgia being a cold spot, and for hospitalizations and overdose reversals, we see Northwest Georgia being hotspots. And then, like I said, we did some modeling to just see whether again, we use these same metro designations, six categories, to see whether rurality level was related to any of these outcomes. And for overdose deaths, we found not at all. There was nothing significant here. For ED visits, also, we didn't have any significant findings. For inpatient hospitalizations, surprisingly, we did have 2 areas that were significantly related to rurality, but in the opposite direction than what we were expecting. So these non-core areas were much less likely to report inpatient hospitalizations, and same with the medium metro. And then finally, for overdose reversals, we found again that the medium metro areas were much less likely to report overdose reversals. So in the end, this was actually contrary to our hypothesis. We really expected to find a gradient like so many other people had. But again, I think this really points to the need to think about rurality more creatively. Again, Northwest Georgia is a lot different from Middle Georgia, and both are considered the same amount of rural, more or less. And so I think that's one thing that could be driving this. And then maybe Georgia is different than some of the other places that we've seen. It's hard to say. Um, but definitely need to explore this more. So I kind of wanted to wrap with just talking about what can we, or what's being done. So I wanted to circle back to the social ecological model and say that just because of all these factors that influence opioid misuse in individuals, we need to take a same multifaceted approach to preventing overdose. And so these prevention practices can be anywhere from in clinical practice, so appropriate prescribing, education of providers, using PDMPs, increase access to medication-assisted treatment. So this is medications for opioid use disorder, increasing telehealth where possible. Harm reduction, so things like naloxone to reverse overdoses, syringe service programs, fentanyl test strips. Another thing we want to do is address the social determinants of health, so things like unemployment and poverty, remove the stressors that are influencing people to misuse opioids. And another important key point is to combat the stigma. I would say particularly in healthcare settings, just because that is an unnecessary barrier to people receiving and engaging in treatment. And then the final thing I wanted to say is really to seek community-based solutions. So in community engaged work, which is basically, people going in and talking to the community, talking to stakeholders and understanding what their priorities are, what they're willing to do. And this really increases buy-in and the chances that a selected evidence-based strategy will be feasible and acceptable. So will it work in the community that you want it to work? And this is especially relevant, I think, where rural culture and resources may differ from where these programs or interventions were tested and developed. So the CDC in 2018 did put out this evidence-based strategies for preventing opioid overdose, what's working in the US. And so again, a lot of it is like what we were just talking about, targeted naloxone distribution, medication-assisted treatment, but also other things like Good Samaritan laws, and we talked about syringe service programs as well. But they highlighted in particular things like treatment centers, criminal justice settings, possibly allowing medication-assisted treatment to be initiated in EDs. Lots of good recommendations there, so highly recommend checking that out. And then specifically, how is Mercer's School of Medicine contributing to solutions? So I had the opportunity to hear actually Dr. Alan Tyndall and his team talk a couple of times about his work in North Georgia. So that's called North Georgia Open. It's the Opioid Prevention and Education Network. And basically it's operating in 4 counties in this Appalachian region of Georgia. And they've done some really good work. They've done things like distributed drug deactivation systems. They've distributed Narcan and trained community members on how to use it. They've established a recovery community organization, which we'll talk about on the next slide. And then they've trained some peer specialists. So what is a recovery community organization? They are an organization that are there to support people in recovery and their whole network, really. And the real beauty of them is that they're located within communities of need and they work to meet local challenges. And they meet members at whatever stage of recovery they're in. So they really take the approach that recovery is not a one size fits all path, but is very unique to each individual. So you can see like they do things like education and awareness, advocacy activities, and provide peer-based support. And so, like I said, Project Open, I think yeah, opened one in Fannin County. And these recovery organizations, they've served over 2,000 people. They've trained almost 350 community members in the lock zone. They've done some stigma reduction training and then referred 112 people to a support service. And when I asked them if I could talk about their program here, they said that they're always happy to hear from people. So I put their email down there. So definitely feel free to reach out. And with that, I want to say thanks. Thanks for listening, and I'm happy to take questions. And also my email is there if you want to reach out at any point.
Thank you so much, Dr. Roth, for this presentation. So if you have questions, you can raise your hand or go ahead and come off mute. And while you all are thinking about your questions and getting ready to raise your hand, so we see who has a question or who's going to come off mute. I see some. Nope. Okay, I thought I saw somebody coming off of mute. Um, I'll open it up with a question. I know you mentioned in the beginning that the designation of rurality is not is its own class and course in and of itself. But then you also hypothesized that maybe some of those different designations might be influencing the outcomes that you found.
Yeah,
Curious to have you hear you talk a little bit more about that.
sure. Yeah. So there currently, I think there are three ways that the federal government designates rurality. The one that we use, the NCHS, I believe it's the NCHS one, is we chose it because it had a little bit of variation. Um, but there's RUCA codes, which I think also have a good spread of variation. And maybe the Office of Business and Management or Office of Management and Business, OMB, whatever that stands for. But a lot of times when people look at rural, they dichotomize things into just rural and non-rural. And we just felt like that wasn't really helpful, just because there's a lot of gradation. But also, if you just think about rural, it, like again, like an Appalachian County is really different than somewhere in the frontier in the Great Plains, which is really different than the middle of Alaska. Um, so I know I've talked with this a little bit about somebody else here about this and how we can more creatively um, describe rurality and see whether types of rural might be more likely to have certain problems. My gut would be to go to what would be called like a latent variable perspective, where you can
Italy.
you can look at indicators and form like subgroups, and that might be a way to describe rural in a more heterogeneous way. So yeah, hopefully those are just some considerations. I've also seen a not super recent, but recent enough paper where they did some cool work just looking at proximity to urban areas and like had these like math formulas that had things like trickle down. So there was like an exponential decay of access to services, and they used that as a proxy for virality and found that that did a lot better than like these other designations that everyone, including myself, use. Yeah.
Thank you. I'll probably be reaching out to you in terms of these models
Okay.
that you all use. I'm interested.
Okay.
I also have a public health background, but yes, so
Oh, sounds good. Sounds
following up
good.
with you.
Any other questions from anyone or comments? We can take comments too.
Well, for one, I definitely feel like I learned a lot, and I didn't even know like the treatments like methadone, norepinephrine, like they're not offered in emergency department settings. Like it's like referred out, and that's something that they can incorporate as well to kind of reduce one, that stigma, but also just kind of assisting those who really needed to kind of um reduce some of those withdrawal effects and kind of create that transition. So that was really insightful. So I appreciate you sharing.
Yeah, of course. Yeah, it kind of blew my mind because the ED is a touch point, a significant touch point for a lot of populations, including rural populations, like we said, because there's fewer like primary care options. And so it just makes a lot of sense to get people started with their medication assisted treatment in in EDs because they might not touch the service system again for a while.
Well, if there are no more current questions, I want to thank Dr. Roth for this very informative seminar. We really appreciate you participating in this seminar series. We will be sending out a survey to all who participated in this just to get people's feedback. And I believe we'll put that in the chat as well if people want to grab it from the chat now. But again, we just want to express our appreciation for your presentation. It was extremely informative, and it gives a lot to think about in terms of just that social ecological framework and the importance of addressing things from multi layers, which we talk about a lot in our just a number of folks on here. I think the folks remaining on here are all representing clinical psychology, and so we definitely think about things from that perspective. And it certainly relates to the Bronfenbrenner framework that we spend a lot of time thinking about as well. So yeah, I think this is aligned with what we're talking about. And we also, as a program, have started connecting with the Open. And so we are
Oh, great.
one of the future partners working together. So I
That's
smiled
wonderful.
presented about
Glad
that.
to
Yes,
hear it. Well,
exactly.
thanks so much for having me. I really appreciate it.
You're welcome. And thank you for our GAs or grad assistants, Bria, Kiana, and Amira, for all of your hard work in helping to pull these seminar presentations together. So thanks, everybody.
Thank you.
Thank you.
Bye, Dr. Roth. Thank you.
Bye-bye.
Bye.
Yeah.